Hello. Hi, everyone. So I'm Corina Chao. I'm a project director with the Institute for Health Policy and Practice out of UNH. Also with Citizens Health Initiative, and within that, we have the Pediatric Improvement Partnership. I have been working here for 5 years, with most of that time working on the Trauma-Informed Care Project, which you might have heard of, which involves adverse childhood experiences, which is what we'll be talking about today. Jan, would you like to introduce yourself?
Sure. Hi, my name's Jan Thomas, and I also work with Corina at the Institute for Health Policy and Practice in Delivery System and Payment Reform. I'm a primary care nurse by training. I previously worked in the Dartmouth Hitchcock system, but the ambulatory throughout the southern part of the state. And my work here at UNH has been around primary care, quality improvement, substance use, behavioral health integration, aging. So across a lot of those areas and using my primary care. So really excited to work with Corina to some extent on the pediatric aspects of behavioral health.
One second, I need to share sound. Okay. So we are here to present to you about adverse childhood experiences and resilience. Are people familiar with the term adverse childhood experiences? Do you know what those are? Okay. So funding for this training is provided by the New Hampshire Children's Health Foundation. Some learning objectives for this presentation is to identify adverse childhood experiences and their impact on both mental and physical well-being, identify public health's role in assessing and treating trauma, describe resilience and ways to foster it in families, and identify aspects of trauma-informed care best practice. So here's a little background so that we all are on the same level ground as we go into the presentation. So number one, research has demonstrated the harmful health impacts of toxic stress on children. 2, pandemic has increased family stress levels. 3, pediatric clinicians are a consistent and trusted source. And 4, partnerships with pediatric primary care clinics and local community supports promotes family resilience. So in July of 2021, the Surgeon General released an advisory titled Protecting Youth Mental Health. This drew attention to the alarming increases in the prevalence of certain mental health challenges brought on by the pandemic and the urgent need to address the crisis. Some of the recommendations for healthcare providers included implementing trauma-informed care principles, routinely screening for ACEs, identifying and addressing mental health needs of family members, combining efforts with community partners, and building multidisciplinary teams. So in seeking to build resilience, it's helpful to look at factors that have been shown to have a negative impact on health and well-being in childhood. So in the original Kaiser Permanente and CDC study on ACEs in 1996, they focused on 10 ACEs, usually referenced as the 10 original ACEs. Those can be found in the household section of this slide. The 10 original ACEs were emotional, physical, and sexual abuse, emotional and physical neglect, having someone in the home with mental illness, witnessing domestic violence, having someone in the home with substance use disorder, having a family member incarcerated, and divorce. So most of the studies that we're going to reference in this presentation use the original 10 ACEs in those studies. So that's just something to keep in mind, that they don't take into account all of the other traumatic or adverse childhood experiences that children could go through. So since 1996, there has been a number of studies expanding those 10 to include other experiences that could still be considered trauma. You can see on this slide, there are also community and environment factors, including poverty, discrimination, structural racism, food scarcity, record heat and droughts, wildfires, and pandemic. We've seen an increase in a lot of these over the last 3 years. And in talking with pediatric primary care providers in the state, most of them have identified that all children who lived through the COVID pandemic experience, that was a trauma for everyone. So just as a baseline, all kids who lived through that have experienced at least some kind of trauma. So going back to the 10 original ACEs, they are very common. About 61% of adults surveyed across 25 states reported that they had experienced at least one type of ACE before age 18, and nearly 1 in 6 had reported that they had experienced 4 or more types of ACEs. Those ACEs have shown to have a graded dose-response relationship. So there's increased risk for poor physical and mental health outcomes through the lifespan, and that increases with the number of ACEs a person has experienced. So the more they've experienced, the higher risk of those negative health outcomes a person has. So when we reference negative health outcomes, this is what we are talking about. There are many of the leading causes of death, like heart disease and cancer on this list. There's also diabetes, obesity, depression, suicide or attempted suicide, and it also increased risk for health risk behaviors and social outcomes. So smoking, drinking, substance use disorder, physical inactivity, unemployment, and lack of health insurance are all shown to have correlations to having a high number of ACEs. This is the leading cause of death list from 2020. You can see on the left the list, and on the right is the odds ratio. So these should be read as, for example, heart disease. Someone with 4 or more ACEs has a 2.1 times more likely chance to die of heart disease than someone who has no ACEs. So in 2019, suicide was in the top 10 leading cause of death, but because of the COVID pandemic, COVID-19 and influenza and pneumonia took place and bumped suicide down to number 12. But as you can see, suicide has a very high odds ratio with having ACEs. People with more than 4 ACEs are 37.5 times more likely to die from suicide. Suicide is a top priority in New Hampshire in terms of prevention in adolescents, and it's highly related to ACEs. So screening for and addressing ACEs is a type of suicide prevention. So this list, I know it might be a little hard to read because it's small text, but take a look at this list of ACE-associated health conditions, and if you could put into the chat 1 or 2, besides the one that directly have to do with suicide, ideation and attempts, that could be related to suicide that you've seen in your work. Self-harm, depression, aggression, ADHD and chronic illness, first use of drugs lower than the age of 14. Great, thank you. So looking at these, it's also important to note that trauma can share symptoms I'm sorry, with other conditions, such as ADHD. A child can present with both ADHD and trauma, which makes recognizing the underlying factors very important so that misdiagnosis and unnecessary pharmaceutical interventions can be avoided. If you look at a lot of these symptoms or health conditions, a lot of them can be attributed to other things, including just normal sickness that kids or people can go through, like stomach aches and headaches. But being able to recognize that someone is at higher risk of these things if they do have ACEs, and that being a clue to maybe screen for it or ask about it, could be helpful to treat it. So this is the DSM-5 description of PTSD in children. So diagnosing correctly helps to target interventions, and you'll see the following in traumatized children: hypervigilance, avoidance, negative thinking or mood, uncontrollable bladder or bowels, physical symptoms with no explanation like stomach aches or headaches, increased or more specific fears, and aggressive or reactive play themes. In very extreme cases, you can see kids with stunted growth or severe detachment from others. And it's also important to note that the expression of trauma does not look the same in everybody. One child might be more avoidant, where the other might be more aggressive, whether both experience trauma. So there's no one way to spot if the child has experienced something traumatic. So as the number, frequency, and duration increase, the children and families can end up living in a toxic stress environment. If they have little access to experiences and relationships that can build the resilience to balance out those ACEs, it can start to take a toll on their bodies. So ACEs can accumulate, and that makes their effects last beyond childhood. So a child who repeatedly and chronically experiences adversity can suffer from toxic stress, and then toxic stress puts the brain into fight or flight mode and releases hormones like cortisol. Cortisol can affect the brain, increase heart rate and blood pressure, and damages the digestive and immune systems. And because those systems have been impacted, it can disrupt their development, and over time, this can limit a person's ability to process information, make decisions, interact with others, regulate emotions, which follows a person into adulthood. We've talked about the mental impacts of trauma, so there also are physical impacts. One is the allostatic load. So the process of toxic stress or chronic stress over time creates a new baseline for behaviors. So each peak on the chart on the left represents a traumatic event. So a child starts at a baseline, experience a trauma, and their baseline goes up a little bit because they did not have the resilience to get back down to that baseline. And then over time, as trauma keeps happening and they can't get back down to that baseline, they then have a new baseline. You can think of this like a car revving its engine while it's at rest. The engine revving in the body translates to changes in brain architecture. Parts of the brain actually shrink when exposed to too much cortisol, which leave the child with reactive fear responses instead of thoughtful reactions to stressors. It affects a number of aspects of the body, as you can see from the diagram on the right. So hormones can create a greater reactivity to stress. Toxin elimination can lead to a gut imbalance. The nervous system, they can't get back down to that baseline level. Immune system can be impacted by causing inflammation, which can cause diseases like asthma and arthritis. The brain waves are impacted, which lead to an inability to concentrate, have anxiety, and seizures. The effect on the neurotransmitters makes people vulnerable to addiction because dopamine transmitters and receptors are not developed, which reduces motivation, and focus creates fatigue, and low serotonin causes depression. And then there can be cellular changes. So it prematurely ages and can cause cancer. A relatively new area of study is called epigenetics, or intergenerational transmission. So we've known that trauma can be transmitted intergenerationally, but there's an increasing interest in epigenetics and the environmental interactions in ACE-induced differential health outcomes. This reference here is a study from 2019 that looked at gene expression, or the turning on and off of genes without changing the DNA sequence, which is what epigenetics is. And they found, for example, that the interaction of two particular genes predicts risk of suicide attempts after childhood trauma. So this is an up and coming field of study that's more be on the lookout for information from this, but it is an exciting way of study going in the field of trauma. Okay, some population considerations. So some groups are more likely to have experienced ACEs, including Black, Hispanic, and Latino, and multiracial people, people in the LGBTQ plus community, people with less than a high school education, and those who are unemployed or making less than $15,000 a year. These risk factors shown here are more associated with social determinants of health, but there is also individual and family risk factors. So in this list, is there anything that you have seen to be a factor in suicide prevention during your work? You can put it into the chat. Parenting stress. Economic stress, caregiver abuse or neglected. Thank you. Families with high conflict, isolation, limited understanding of mental health. Okay, so that has it's all been very negative so far, with learning about all the health risk factors and negative consequences of ACEs. But there is hopeful side of this, and that's resilience. So resilience is a good outcome in the face of adversity. So even if someone has a high number of ACEs, if they also have high resilience, the risks of negative health outcomes can be mitigated. So having a high number of ACEs doesn't mean that you have to suffer any of those negative health outcomes that we talked about. Next, I'm going to show a video on the importance of resilience from the Harvard Center on the Developing Child.
Resilience is not some magical quality. It's something that really can be built, even in difficult circumstances.
The key active core ingredient to building resilience are the relationships the kids have to others who care about them.
Of course, families play a very important role, but nobody raises children in isolation. We have a huge amount of research to show the powerful impacts of teachers, coaches, other adults in the community with whom children have a chance to develop relationships, who play that critical supportive role of building resilience. As a result of responsive interaction, children build simple skills of coping and adapting. How to stop crying, how to regulate your behavior, being able to defer gratification.
You have an adaptive toolkit that allows you at moments of stress or challenge to bring out a number of potential skills that allow you to get through it.
As children get older, the sophistication of those skills increases. Being able to monitor situations, solve problems. The way we as a society can nurture the development of resilience is to help communities to pay more attention to building the capabilities of the adults who care for children and provide the supports they need to tip the scales toward more positive life outcomes.
And then when communities say, we want to be an active part of crafting the solution to really understand what's necessary to produce the resilience, that's when the ball ball gets rolling.
Resilience building, capacity building is really in everyone's interest, and everyone reaps the benefits when we do that well.
Okay, so next we're going to talk about positive childhood experiences, sometimes referred to as PACEs as well. So this is work Bethel and her colleagues did with PACEs. On the left, you can see the 7 PACEs they studied, and on the right, you can see the impact that these PACEs had on mitigating the risk presented by ACEs. So this is a limited list. They only studied 7 things. This is not just like the original 10 ACEs, this is not the end all be all of positive childhood experiences. This is just specifically what they studied. And as you can see, only 3 of these 7 PACEs had to do with family. The other 4 had to do with community, and other people outside of the family being able to help build that resilience and give them positive experiences. So even if they are getting no PACEs in the house from the family, if they get 3 or 4 from the community, they'll see a 50% less likely to have adult depression, which can help in suicide prevention. If they have 6 to 7 PACEs, that's 70% less likely to have adult depression and 3.5 times more likely to have social and emotional support as an adult. So PACEs are a great mitigating factor for ACEs. Just like there are risk factors that we talked about, there are also protective factors. This is a list of protective factors. Is there anything on this list that you feel you could do either individually or as your organization to aid in suicide prevention, or things that you're already doing that you can identify? And you can put those in the chat. Engaging in fun and positive activities. Nurturing relationships. Working to improve basic needs. Oh, that's great. You offer support groups for adults who experienced DV or SA. Listening and engaging with people and conflict resolution. Great. The next, we're actually going to talk more about both of those and nurturing relationships. So there's something called SSNRs, which is safe and secure nurturing relationships. Studies show that the ability to be resilient often boils down to relationships. And sometimes even just one relationship can give a child a secure place during hardship, and that doesn't have to be in the home. Such a relationship can buffer the negative impact in these areas, creating a sense of safety and security. The child feels confident taking risks and trying new things. So the aspects of this: safe, the child is free of physical or psychological harm; secure, the adult is dependable and there for the child; and nurturing, their physical, emotional, and developmental needs are sensitively and consistently met. And again, this does not have to be a person inside the home. Anyone can provide a safe, secure, nurturing relationship to another person or child, even if they don't live with them. So these are 5 tips for providing a safe, secure, nurturing support to a child specifically. So talking to a child, checking in about their life, being a good listener, which someone mentioned, that can sometimes be all that someone needs, is someone who can listen to them and pay attention to what they're saying. Being consistent, doing what you say you're going to do allows the child to know what to expect and to feel safe. Showing up, attending important events, and prioritizing their needs to make them feel special and wanted. avoiding shaming the child if they make a bad decision. The most important part of a safe, secure, nurturing relationship is the unconditional support. And then don't aim for perfection. Again, you don't have to be perfect to make a positive impact on a child's life or anyone's life. So in the trauma-informed care project that we do, we really highlight that screening alone is not sufficient. A lot of times when you bring up trauma or adverse childhood experiences, the response from people is, well, we don't have enough mental health, we don't have enough therapists to send people to. And really what we're trying to show is that that is not necessarily what is needed to create a resiliency in a child or a person. So screening alone isn't sufficient. A trauma-informed care pyramid is on the right. So it starts with patient-centered communication and care, understanding the health effects of trauma, and that is not just for a practice, that is for a whole community. Interprofessional collaboration, which is what you all are doing. Understanding your own history and reactions is important, especially if you're working with children, being able to recognize your own traumas and how that could impact how you can help someone. And then screening is at the very top. So becoming a trauma-informed community relies on everyone, including individuals and community supports, being aware of the effects of trauma and being open to interprofessional collaboration. In the Trauma-Informed Care Project in your area for Carroll County, we have been working with White Mountain Community Health Center to implement screening and connect them with community partners like you all. So people in your community are being screened and educated on the effects of trauma, which could lead to increased conversations that you have with people, people being more open about the trauma that they've experienced or the help that they need, and increased referrals to community partners and things like that. So that is happening in your community, and you should be aware of it. So now I'll hand it over to Jan.
Thank you, Corina. Yes, and just wanted to reinforce what Corina said, that this project that Corina and our group have been working on is focusing on screening and how can we have that happening at the clinical end. And then Jen was involved because then the next step is, what do you do with that information? How do you help the child, the family? And you need those community resources that are out there, and you are such a major part of that. So we want to thank you, Jen, for coming to us, because we didn't know this project would continue to reach it and grow. So we look for your support, and if you know people that want to get involved in this training, we certainly would help them. And as Corina said, the positive side of this is building the resilience in action. And we feel you are such a major part of that. The clinical side, where I'm from, we just start the process. Yes, there's a relationship there. You folks add so much to that. So we wanted to give you more information that you may already have or maybe didn't, on how to recognize the impact of those childhood adverse events, those ACEs, that maybe some of these things that Corina brought up you hadn't thought about, or that you might not realize the situation or something a child or a youth is speaking about, or even how that's involved in your suicide prevention, that maybe you hadn't made that connection. So we appreciate you interacting with us and talking about that. And we know you do a lot of educating with families. Oh, Corina, can you go back just so we can get through that? Promoting those relationships, which Corina just talked about. And then this is where we find Jen and your group as family resources to the clinical side, is those in-office brief interventions, or that when someone reaches out, where are the places? And if you know about them, or can you refer these primary care folks who are so desperately want to help, but many times they don't realize you exist out there. That's sad. And yet, on the other hand, how can we continue to promote that? So we hope you'll be involved. If we will hope to do even more projects of doing the training at the primary care sites. And then we're going to need wherever that community is, or wherever you are, how can we connect with you? So we we are so appreciative, Jen, and we look forward to doing this in more counties around the state. Corina, I believe we've done, are we at 8 different sites now? I believe, total over the 2 years, 8 or is it 10?
10.
10. So we've reached 10 practice sites of primary care. So that's not bad, but it's not everywhere. And have we reached all the counties yet, Corina? I don't think so. I think
No.
we've gotten in like 5 or 6. So again, lots of work to do, and we appreciate any connections that you can help us with. So next slide, Corina. So, well, you know this stuff. Individual therapy may or may not be what's needed. You folks supply so many things that Corina talked about. An adult who can be safe for them, a place where they can feel safe or be taken care of for a while, or just to get away with it, get away from things that are happening. The fact that the 988 hotline has now been put in place, and we know some of you are connected with how those responses happen. So again, being aware of that. So we unfortunately, as primary care, look to you to help us. What do we do when we call? We appreciate, even if it sounds silly on our end to say, we don't know what to do. We do appreciate when you can even say, here's this number, or did you know this existed? So we appreciate that. Next slide, Corina. And these are just samples of the group that Corina worked with. They actually took the evidence, took the research, utilized a number of national experts in trauma-informed care for children, and wrote these 2 guides that can be used in a clinical practice. You could use them in community, but they are very focused at the actual health treatment of clients or children. So, you could modify them, but if you have any interest in learning, there's a lot of research information. There's a lot of references into these guides. And if you're in a practice, or even if your kids or family, recommend them if they'd like to get connected with our group. We would love to try to promote, again, more of this screening of trauma and other developmental items and training screenings that happen for children, so that we can prevent or promote more resilience. So those are available, and I think Corina has put links to where they are in our references. I think that's it. Next slide, Corina. So there's a whole lot of resources, and then I'm going to turn it over. If you have questions, Corina really is here to answer or give more information.
Thank you both. Yeah, if anybody has any questions, speak up. You'll be able to share those slides and resources, correct?
Yeah, I'll send you a PDF of the slides, and there's our references at the end, as well as some additional websites.
All right, I can attach them to the minutes for everybody. Awesome, thank you. Does anybody have any questions or comments? Or
I just think that was fantastic. I think it's a very upstream approach when we're thinking about, those at high risk for suicide. And, I just think it was fantastic. And I love the thought of, like a trauma-informed community, not just a trauma-informed individual working with another individual. It's almost like that, following that saying, it takes a village, yeah. So just thank you so much for this.
Susan, that's we'll have to, Corina, write that down for our next team. Yeah, that's excellent. Thank you.
yeah, that gives me lots of ideas to look into too. You always focus on schools for trauma-informed practices. So that's, yeah, it's a good thing. Good thing
We've
to look
heard
into.
that libraries are a great place. There's been multiple studies and papers done about trauma-informed libraries being a center of a community, and them providing resources and information about where to refer to and things like that. So yeah.
Yeah, I've been noticing that, and some libraries approaching me for all different types of programming for youth, and they're always a hub anyways of activities. So it is a good place to look at. Yeah.
And Corina, would you say also, even though you focused, your particular project was very focused on youth, a lot of these do apply to adults, and there are some slight variations, but it's not just that it's children.
Yes.
All right. Well, thank you. I just have like a slight question, mostly because I don't quite understand. Well, the screening process for ACEs at schools. I know we've had this conversation before, not schools, primary care or general practitioners. How you go about, how do we go about like increasing their awareness about the health conditions that might be related to ACEs? Like you said, they're just prescribing medications in that general range as if it's a common health condition versus caused by ACEs. How do you go about raising awareness for that? I don't know if what you're already working on as far as that goes or what information you have, but I'm always kind of curious because they're always they're in a hurry, they're backed up and short staffed like everybody else. And how do you kind of get them away from that thought process and say, hey, you know what, maybe this is a little different than what I'm thinking it is, because you see that a lot sometimes. They just give you the meds.
Right. So the practices we've worked with in the project, to make the parents more aware of the health effects, a lot of them before they started screening sent out either by email or by letter, something telling parents that this is something that they're going to start doing. So they do it, some of them do it at every well visit, because of course, trauma can happen throughout the year, so they want to keep up with it. But that letter usually contains, this is why we're doing it, this is why it's important. You can decline if you would like to, but these are the reasons why we're going to be screening. And they're starting from a very young age, so they're hoping to not only catch when there has been trauma, but hoping to prevent the trauma. And when we've talked with our primary care providers who have implemented this screen, they have said that it does not increase meeting time, like the amount of time that they have with the patient. So some concerns that we had heard before we had done the project were that it was going to make the visits longer, but we didn't find that. So that hasn't been an issue.
And Corina, I would say you brought a lot of evidence, your team brought a lot of evidence to the clinical folks, whether that's the providers, the supporting staff, even the frontline staff that are making your appointments or checking you in. So you involve the entire team when you do this project. So it's not just that you're talking to the provider about trauma. You are really educating an entire team of people to make their community bigger. And I think you also looked at how could it be as efficient as possible and yet also as caring as possible. And you have a lot of conversation. They have a lot of discussion as a team before they implement, and they choose how they're going to implement certain screening and which type works best for the population they feel they're treating. So it's fairly intimate. Didn't it take folks almost a year, Corina? It's not as if this just happens like that.
Yeah, it's about 6 months of planning. So that's like choosing what screen, training the staff, choosing a workflow, who's going to administer the screen, things like that. We also have our trauma 101 and a 102 training recorded on our website. Some practices have implemented those recordings into like onboarding staff, so that even when they get new people, with turnover being high kind of everywhere right now, everyone comes in with an understanding of what they're doing and why they're doing it. We also have a trauma-informed care toolkit on our website that has a lot of resources, including sample workflows, sample registries, a lot of tools that practices who are interested in implementing trauma-informed care in a screen could use if they're not able to work with us directly.
What is the name of your website?
It's nhpip.org. I can put it in the chat.
Thank you. And thank you for the question, Jen, because that makes I would think the same thing. How do you make more time when they don't have time?
When you speak of teams, like who do you like, for an example, what is like a team like you have together now? Like what individuals? Because I'm thinking of schools that see these kids a lot too. Are there any school personnel involved in the teams?
Not currently. We just work within the primary care. But we do have some other work on a different project called the Mental Health Care Access in Pediatrics Project, that is going into schools and working on connecting like school nurses, school counselors, social workers that are in the schools with the primary care providers, for all aspects of pediatric mental health, not just trauma, but that is included.
Yeah, that's great because there's, I always think this, the practitioners in the schools should kind of talk a lot. So,
And Corina, when you say your pediatric access program, we're trying to focus hopefully the next couple of years, a lot more on collaboration with schools, Jen. So previously it was very much focused on the clinical side, and now you hopefully will be having quite a bit more impact and interaction with the school nurses, school counselors that have to do with those type things.
all right. Could you provide that, that link as well for some information on that as well?
Yeah, I can send that all to you right now in an email, and you can add it to
Beautiful.
minutes if you'd like.
And when you say, Corina, if folks are interested in your Trauma 101 or Trauma 102 trainings, again, they are online if you want to just watch. On the other hand, if you are interested in having folks come, we have two other trainers that work in this space with Corina, and we certainly, promote that. Contact Corina directly or the PIP, and we certainly will try to find a way to do that.
Yeah, and this one was slightly adapted. So the one that is recorded on the website is more focused on the clinical, but we're happy to adapt it to whoever wants to learn about it.
All right. Well, thank you so much. I really appreciate you coming in and talking to us about this. And I can share out that whatever information you email to me, you're okay with in the presentation, because there's a lot, like I said, there's a lot of great resources on the slides. And we like to share resources out to everybody. That's what we do, and try to make those connections. And thank you. I hope you guys have if you ever have any questions, please reach out. And if you see any contacts you'd like to make, any connections you'd like to make, please let me know. And,
Thank you.
all right. You're welcome to stay and listen to the rest of it. If not, hopefully we'll talk to you soon.
Thank you.
Bye.
Bye. All right. Well, thank you, everybody. Hope you enjoyed that and learned a little bit.
Stop the recording.
Okay. We're going to stop the recording, and we're just going to